Welcome once again. You're watching Boritzer's Bio Briefings right here, downtown Honolulu. And you're hot, we are not. And our topic today is hot technologies from the past and in the future. What I'd like you to pay attention a little bit, I'm going to go and reminisce. You know that I'm somewhat of a raconteur, a storyteller. Like to go back and trace my antecedents, whether technological or cell lines. In any case, today we're going to be talking with my special guest. I'm going to be delayed a couple of minutes before I show him live, but our guest today is Mr. David Pollack. David Pollack is CEO of ADL Data Systems, a company that superseded one in which I was involved with David years ago called Interactive Medical Systems, if I remember correctly. One of the early health information management systems. But I don't know if I've mentioned it before. You know that as a professor in the UH system, I like to be the grand inquisitor and ask my students questions and see if they have a recall of the past, the present, and perhaps some omnipresence in the future. The usual questions about technology, and it kind of lets me place where students are in the timeline of my own biography. And one of the things I always ask is, do you remember when there were no fax machines? And students usually look at me quizzically and say, no fax machines? What are fax machines? So, yeah, well, they are a little dated, even though they did come on the scene rather lately in the 20th century. They showed up about 1960, and the early fax machines were very interesting because you had to have a telephone modem connecting, put earpieces over it. It heard a signal, which was the forerunner of zeros and ones electronically that we're so used to on computer programming. But what they did, they were able to use bit data to transform an image and then send it over the telephone line. It was a very complex operation. So if you don't remember when fax machines did not exist, perhaps you don't even remember when computers did not exist. And that is the beginning of my story with our guest today, David Pollack. When I first met David Pollack, I had been a very frustrated person, and I'd been trying to set up an early healthcare information system that I was trying to even design myself because I did not have the money at the healthcare facility I was managing in New York City. The healthcare facility was an 861-bed facility, and we just were inundated by the amount of information, paperwork, and record keeping that were required of us by the local, state, and federal government. So I decided that I was going to try to use one of the big computer companies at that time. They were McDonnell Douglas, SMS Medical Systems, which all required online, also, as I mentioned, with the fax machine, a modem to receive and transmit data. A very primitive operation by today's standards. Within about 20 months of heavy expenditures of financing and also personnel time and very primitive data collection procedures, we decided that we would try to do it in-house. And that's where really my story rather picks up with our guest today, David Pollack. David Pollack was simultaneously trying to do the same thing on perhaps a more systematized basis, trying to serve a whole industry, at that time the New York City long-term care industry, and trying to create a standard that would eventually become the standard. But before I do that, let me introduce David Pollack. David Pollack is joining us today from his headquarters office in Hawthorne, New York. Some of you may know it as part of the snow belt for the last 2 weeks. I believe that David came in on his snowshoes today into his office, and he joins us right now. Welcome, David.
Well, thank you, Rafi. It's great to be speaking with you once again. As you pointed out, we're having an awful lot of snow here, and it kind of makes me feel a little jealous of you.
Well, it happens. Yes, you're always welcome to come here, as you know well, and we're waiting for you and your wife to come and visit us right here in Honolulu.
Well, I hope that not in the near future we will get to see each other and probably have a lunch together.
Okay. Go ahead. Tell us a little bit of your story. We'd like to hear how this all came about. Yeah, I remember we met around 1976, if I remember correctly, and started working together, trying to overhaul the archaic ways in which record keeping was done in New York City in those days.
Well, our story starts out about 4 years before that period in time. Actually, going back to our college days, I switched my major from, I was studying to be a physicist, I switched to computer science. The first computer science degree in the country, actually. So much so that when I came home and told my father, you know, I switched majors, he said, what did you switch to? I said, computer science. He looked me in the eye and he said, are you telling me you dropped out of school? He couldn't believe it. But it was true. City College Engineering had started a new program on computer science, brought together some of the most finest computer minds in the country. Most of the people at that time were really not professors so much as they were industry scientists, people that wrote the books on computers. And so I started my journey into the world of computers. I found it to be very much, very enjoyable to myself, something that I sort of had a natural kind of proclivity, you know, toward. Whereas I was good in math, but I was not a exceptional math student. And I thought that a physicist had to be a good one anyway, would need to be exceptionally bright in math, of which I was good in math, but not exceptional. I hope that I am exceptional in the computer area, but nonetheless, that was the beginning of my change into computers. And at that time, we were working, myself and Aaron Weg, who's my partner. We were both in the computer science program, this newly found program, and we were both working for the City College Science Foundation, doing computer programs for the engineering professors. And one day, one of the professors comes over to me and he says, I got a job for you. You have to do me a favor. We have this friend, a doctor who owns a nursing home. He's been trying to computerize it. He's not having much success for the last couple of years. You have to go down and help him out. So these two young students took their journey down to the nursing home, where we found a doctor who owned it, very brilliant surgeon, and he was also like-minded as you, was trying to computerize his operation. He actually had bought at that time what was one of the first mini computers in the country. It cost $200,000 for a machine that's probably less than your calculator, your hand calculator. But nonetheless, we sat down and we started programming, and the next couple of years we brought up a lot of functions related to the nursing home. He was also very brilliant in figuring out systems like patient assessment systems. He was very clinically oriented, not so much accounting oriented, although the first area that we did address was the accounting, and then went on to do some clinical work. And we were doing this for a few years, and as you will find out, not much has changed in the industry. There was not that much money available for computerization. The story, by the way, hasn't changed very much. A lot more computers are needed today, and there's just not that much money for training, for equipment, for the latest equipment, for workflow changes. A lot of this stuff is done by dedicated people, pretty much working hard, almost for nothing. But nonetheless, we started this development effort. And a few years into the development effort, the doctor says, you know, I really can't afford to continue paying for all this development work, so I'd like to make you a deal. I will become your test facility, and we'll be a guinea pig, and I'll pay you some maintenance, but I can't pay you full development, and you can use the software and go out and build a company and address the industry. And at that point, we went out to sell the industry, and the response was pretty much the same across the board. That's kind of interesting, but I don't know that I really need it. And so the first year of doing business in 1977, we sold exactly no systems. And then the scandals in New York broke. And a few people went to jail. And the government decided these systems were no good. They needed better controls. So they started putting in the Uniform Chart of Accounts, which was a very detailed general ledger. They put in electronic billing, which they were asking nursing homes to submit their bills electronically so they can keep better track of it and monitor it. And as a result, all of a sudden, nursing homes were turning around and looking for systems that pretty much didn't exist outside of us and maybe one or two other projects that were working around the country.
Hold that thought, David. Hold that thought. And we're going to take a break for our sponsor announcements and let you know where we are talking to and with whom. We'll be right back with our guest today, David Pollack, as the CEO of ADL Data Systems. Thank you.
Castle & Cooke, Hawaii. Investing in Hawaii, creating communities, and providing for the needs of our state. Collateral Analytics, empowering the real estate industry to make better informed property investment decisions. The Foreign Trade Zone, bringing the benefits of the Foreign Trade Zone programs to Hawaii businesses and entrepreneurs. Galen Ho, a senior executive of BAE Systems, a global defense, security, and aerospace company. Hawaiian Electric Company and its affiliates Maui Electric and Hawaii Electric Light Company on Hawaii Island. The Hawaii Energy Policy Forum, incorporating diverse perspectives to design a flexible and forward-looking energy strategy. Hawaii Energy, the state's energy and efficiency program created to help Hawaii's residents and businesses adopt a clean energy lifestyle. Hawaii Gas, helping Hawaii achieve its transition to clean energy and a better energy future. Hawaii Pacific Health, bringing technology and teamwork together to transform healthcare in Hawaii. The High Tech Development Corporation, attached to DBED, is the state's leading technology agency. The Scheidler Family Foundation, supporting educational, cultural, and charitable organizations, including think tanks.
We're talking to our guest, David Pollack, the CEO of ADL Data Systems in New York State. And just to mention a short little anecdote of about 10 seconds, in those days, you must realize that the data and the systems were actually very large disks. Each disk was about 5 megabytes on an equipment called PDP-8s. These were the Digital Equipment Corporation. Digital Equipment is no longer in business. It was one of the mini computer makers. And I'll let Dave pick up the story from here.
Okay, so in continuing the story, as scandals broke out in New York City, the government started demanding a lot more data, a lot more electronics from the nursing homes. And their accountants kind of threw their hands up in the air and said, 10,000 accounts, general ledger accounts, from 500, we need a computer. And all of a sudden, we were in the business of selling computers. It seems that if you look in the actual history of the company, every couple of years, the government creates another crisis, brings in another radical system that they require the nursing homes to comply with. And then there's a tremendous wave, sort of like kind of like the big wave that the surfers surf in Hawaii. So we sort of surf that wave of technology demands, and that's how we've grown the company over the years, through these technology spurts. And so that's sort of put us on the map, and that's probably approximately the year that we met, when the nursing homes were beginning to start to looking for these systems and starting to buy these systems. And that's when we kind of got together. The first systems, of course, concentrated on accounting, mostly the billing, and some of the very specialized systems that nursing homes have. It's very unique to the nursing home business itself. It's not seen in almost any other businesses. And I refer to things like patient trust funds. Because the patient, or the resident, as some places like to call them, it's their home. They're not in a hospital, and they're not there for the short term. They're really there for the duration of the rest of their lives in most cases. So the nursing home has to act as their home. And sometimes it has to act as their banker, has to handle their allowance money. So typically, most nursing home patients are on Medicaid, which is the government-sponsored program for paying for indigent people that cannot afford to pay for it. That's the majority of the nursing homes. I would say close to 90% of most patients in the nursing homes are subsidized through the Medicaid program. But part of the Medicaid program calls for taking the monies that the patient would get in his pension funds or his Social Security checks and applying it toward his stay at the home, except for the allowance money that they're allowed to use for their own personal enjoyment. Spend it as they like to spend it. So the nursing homes have to run this small banking system where they give bank-type statements. They also provide interest for the monies that they hold in the account. And it's a whole little, actually, private banking system. There is virtually nothing like it, except in, believe it or not, the prison system. The prisons also have a similar type of system. But this is unique to the nursing homes, and this is some of the specialized accounting software that we had to put in order to comply with the auditing regulations and the auditing considerations that a nursing home has. And these are the kinds of systems that we worked on initially. Except for Dr. Lichtman, who was the owner of the nursing home that I'm talking about, he actually was writing some acuity systems, and basically he didn't really have a game plan for it as far as the state was concerned. He was really just more interested in what was the problems that his patients had and how could he service them better. That was really the idea behind his acuity systems. But much later, if you'll recall, approximately toward a little bit before you got out of the business, the nursing home business implemented a system called RUGs, Resource Utilization Groups. And the basic idea behind RUGs was to evaluate a patient, determine what problems he had, and from there be able to calculate what utilization of services he would need. How many nursing hours would it take to take care of him? How many aid hours? How many hours would the aides have to be dressing them and feeding them and walking them around the nursing home? So that became the forerunners of some of the systems was the systems called RUGs, Resource Utilization. And that, the government was actually interested in that, in being able to figure out how to pay the nursing homes, basically how to reimburse them. So they were figuring out how much effort, how much money was going into taking care of a specific patient in a specific RUG group.
Let me ask you a question here, David. Let me ask you a question, which really came up because, as you know, my family was also in the nursing home business at the time, and so was I. And one of the assumptions underlying this governmental concern with cost, which is a natural kind of interest of most governments, is cost control, especially when they are paying a large portion of the fare. And looking up ahead 20, 30 years, they were anticipating even more expenditures on long-term care because obviously the care was going to get more expensive and more people would need chronic health care and care in their senior years. So when the government is looking at this, it can't obviously also want to give massive standardized care and cost supervision while giving quality care. Is there a dichotomy here, which is basically was built into your system?
I don't know that there's a dichotomy. I think that to a large degree, if it's done, I guess people can use it in both directions. You know, your mother, for example, was the type of person that used it to better her patient care, control her costs, and at the same time, the state would get a controlling cost as well. Your mother always seemed to take all sides should benefit. The state should benefit, she should benefit, the patient should benefit. There are those people that take the positions and use the data for just the opposite, as you call the dichotomy. The state will use it not to pay you because, you're not delivering service, or you just didn't document correctly, or whatever it is, and they will use it for cost containment. But in general, I think personally that if reasonable people are committed to the same goals, it can be used effectively in containing costs and still within those costs assuring that the patients are getting the best service possible.
I see. Well, you know what? That's an interesting point. It's not a point that's solely in the realm of healthcare. It's also in the realm of education, many other services that government subsidizes. In terms of education, the documentation is sometimes more important than the service delivered. And in healthcare, we know just from lawsuits and the fear of litigation by many physicians and insurance company that the documentation becomes even more critical. What role did this have in the development of your company, the success of your company, and the proliferation of your product throughout the industry in the country?
Well, I have an interesting story about this that relates back to a particular nursing home chain that called me many, many years ago, and they wanted a quote on an electronic medical record. But I mean a full paperless electronic medical record. So my first question to them was, what do you mean by an electronic medical record? And they says, okay, wait up. And the next day, Federal Express, a folder arrived with a copy of every document that nursing home uses. The folder was 2.5 inches thick, just with the forms. They weren't filled out. They were just sample forms, 2.5 pages thick. So I called up the person and I said, I don't want to quote you. And the person says, why would you want to quote me on this project? I says, because you'll never pay for it. And the person said to me, well, we've had a good relationship all these years. I strongly advise you to quote on this system. So I said, but it's going to take me weeks just to figure out how many different systems, from assessment systems to behavior tracking to the mood of the patient. I mean, every aspect of a human being's life basically was being documented in these documents. So I sat down. It took about 4 weeks. I sent her the quote, which was a phenomenal amount of money. And I waited a couple of days and then called her and said, are you still sitting in the chair? Did you fall off the chair? She says, no, I'm still looking at this. And, we're strongly considering giving you an okay to do it. And my first question was, what changed? Why would you want to spend this kind of money when in the past no nursing home were able to spend this money? The nursing home person, the executive that I was talking to, said to me, do you know how many lawsuits we have? And I said, no, I'm your computer company, not your attorney. And they said, well, to give you an idea, currently they're coming in at the rate of 2 every week. There are 125 lawsuits that we are dealing with right now. And the only way that the lawyers can see an entity's lawsuits, or at least a good defense, was to make excellent documentation that not only was you just documenting the forms, but everything that was being done in the form was cross-referenced so that the documentation had referential integrity. In other words, if the doctor was writing one thing, the nurse better be writing the same thing or on the same issue. And not that the doctor says one thing and the nurse is saying something completely different and the physical therapist has a third opinion. Because then it looks like you're not taking care of the patient. And subsequently, any chart that you pull throughout the nursing home, not just this chain, but almost any nursing home. Okay. There are logical inconsistencies between the different people recording their subjective opinions. And part of what we had to do was to cross-reference all the data in all the forms and be able to validate that everybody was talking about the same patient and the same problems and the same level of problem.
Hold this thought, David, and we'll be back in a couple of minutes right after our commercial break.
I'm Hong Jiang, host for Asia in Review on Tuesdays.
And I'm David Day, host for Asian Review on Thursdays. Both of us broadcast our respective shows at 4 p.m.
And my topics tend to deal with questions related to environment, culture, history, and sometimes human rights.
And my shows tend to be on international business, foreign policy, geopolitics, and national security. And you can watch our shows live on the ThinkTech website at thinktechhawaii.com.
And you can also watch us on YouTube or Olalo.
So come join us on Thursdays at 4 p.m. I'm David Day.
And on Tuesdays at 4 p.m., I'm Hong Jiang.
Aloha.
Aloha.
Once again, you're hot, and we are listening to the guru from New York talking about medical management information systems, his start, his chronology, his journey, and the obvious similarity with many other governmental finance functions, that evidence is more important than fact. And so we've got David Pollack. Please continue, David. Tell us a little bit about how this obsession with proof, especially in a litigious society like the United States that requires that you be able to prove in court everything you did or did not do or did not show any malpractice. How will this change with the advent of interfaced electronics that measure all kinds of activities in which the patient might participate, get, receive, or use?
That's an excellent question, Rafi, but it requires a little clarification because I need to give you some ground rules about documentation and procedures and what's happening in the field in general. While a lot of these systems are assessing and we are tracking and we're trying to cross-reference so that the documentation has its own integrity, the documentation standard is actually becoming almost a weapon against the nursing homes to a large degree. Because let's take a typical example of documentation, and where documentation is good and also where it turns out to be not so good. In our systems today, we have a lot of what's called, back in the days, let me digress 1 second because I want to give you a little bit of a story because it's related to this system as well. Many years when we first started, many years back, and we were doing the accounting systems, I received a call from a nursing home owner to come to a special meeting that she had set up. This owner happened to be your mother, Rose Boritzer. And we went to this meeting, and in this meeting, she had all the different departments, dietary, nursing, housekeeping, all the different departments she had at this meeting. What was notably missing at the meeting was accounting. Accounting wasn't at the meeting. And Rose started off the discussion with, "You've done some wonderful stuff for us in accounting. What are you going to do for us in the clinical area for the rest of the nursing home?" And I says, "Well, what do I have to do?" And she says, "That's what the meeting's for." And she sat down, and in a round table, each one of the department heads expressed to us what they needed to see out of computer systems and information systems. And then I turned to your mother after the meeting was over, and I says, "But this is a very cursory explanation of what you need. There's a lot of detail." She says, "You know what? I took care of that already." I said, "Really?" She says, "I called my friends that own the other nursing homes. Men like Herb Rothman, Jack Friedman. And what they did was they all got together and each one hired an industry consultant in each different area to sit with us and explain to us what an electronic medical record, a certain part of the electronic medical record. So we had a dietitian explain to us what dietary does and how dietary interfaces into the medical record. We had another person sit there and explain to us how order entry works. And that's our first introduction into the electronic medical records. It was all thanks to your mother and her friends, by the way. Now, getting back to the documentation portion, one of the most critical and well-accepted systems in the industry today is a system that your mother identified with the pharmacies being the order entry system. Pharmacies have been pushing the order entry systems because if the nursing home enters the order, they do not have to, and therefore they can reduce their costs, their labor costs, on their end, getting the messages electronically through HL7 messaging. Okay?
Roger.
Now, once the medications are known to the pharmacy then sends the medications in their little carts, fills the carts for the nursing homes. And the nursing homes now go around with a very advanced system in which they touch a screen, they see the patient, and what meds at what point in time, in other words, for this moment in time, which meds they have to give the patient. And they will sit there and give the patient the meds and touch the screen indicating that the patient got the meds. This is a wonderful documentation system. It's a terrific system because it tells you exactly when you have to give the meds. Correct?
Correct.
Seems like a dream come true.
Yes.
Not so. Because it turns out that a nurse are understaffed. And there's usually one nurse assigned to some 20 or 40 patients to give the medications. So during the course of the day, when she has to give the med, she starts the round. It may take her anywhere between 40 minutes to an hour and a half to complete that round. So the patient that was supposed to get the med at 10 o'clock is not getting it at 10 o'clock, they're getting it at 11 o'clock or 11:30. Or sometimes they forget and they get it at 12. The nurse has no way to override these systems now. So the system is documenting that they're not medicating the patients on time. And then sometimes they start over-medicating the patient. They documented that they document ahead of time, illegally, so to speak. They'll document ahead of time they gave the meds, and then give the meds on the regular time and not have enough time in between the meds.
Unbelievable, unbelievable.
So these systems are good, but there's a reality factor that has to be taken into consideration. And the legal system is not taking this into account. The nursing homes do not have dozens and dozens of people to give out meds. They only have 1 or 2 people on a nursing unit. So there's a reality factor that the law does not seem to recognize, and people do not want to recognize it. Another example of over-documentation was I got a call from a nursing home that they wanted to keep pictures of decubitus wounds on the patient and store them like in a file, sort of like a Facebook type of file on decubitus.
Those are known also as bed sores, yeah.
Correct. That's one of the biggest areas that people get sued on, bed sores, because bed sores get worse, then the patients get infections, then they get very sick, and sometimes results in death. Not necessarily due to the bed sores, but due to the infections that the patient starts developing later, especially when they start coming down with things like pneumonia. But I said to the person, do you really want to document these bed sores? They said, why? Seems like a great idea. I can show the bed sores. I says, yeah, well, it works well when the bed sore comes in from the hospital and you document it. But if the bed sore develops while the patient happens to be in the facility, and sometimes these bed sores develop strictly because of the patient's condition and not really due to any miscalculation or
neglect, yeah.
Or neglect of the nurse. The nurse can't go around checking every couple of minutes a patient and they can't turn him over. It's very difficult. You're not going to take a person sleeping in a bed. You're not going to turn him over and wake him up. So in any event, but now you're documenting this case. So the patient came in, no decubitus. By the time you're photographing a stage 3 or stage 4, these are pictures that people find very, very sickening and can lead to jurors getting quite emotionally sick looking just at the picture. I said, do you really want to be showing the picture that you missed treating the patient and here's the result? It's better to say he had a level 4 or a level 3 than it is to sit him and show him a picture of what it really looks like.
I see. So in what role do you see, what will happen as is the perhaps a direction that many services that were formerly done by professionals or paraprofessionals, what will happen when we ask patients to participate in their perhaps medical health or medicating services? What happens? How will you document that, and how will a patient be able to participate in entering into the electronic data systems this kind of information?
Well, Rafi, the question really is a strong question for hospitals and the continuum of care when a patient is being has a problem like diabetes at home, and that continues now to his hospital stay. When a patient reaches the nursing home level, in today's environment, he's really quite sick, and I would say that a majority of them suffer from some level of dementia. You really can't rely on that patient to take care of himself. Perhaps in the senior living centers, you can get a little bit more of that, but even there, the patients tend to forget they took pills, when they took the pills, just how much pain they had 2 hours ago. It's becoming patient care. I'm a big advocate of patients and families being involved in the care of their loved ones. But I will tell you that in the nursing home and in the long-term business, you're not going to see, especially what's coming down in the future, very, very sick subacute type patients that are really not going to be able to take care of themselves or give you much guidance in that matter. So the families are going to have to take bigger roles. The nursing homes are going to have to be monitored much more to make sure that they are doing what what standard protocols call for. It's just a fact of life. Interestingly enough, by the way, it was predicted in the next 25 years when we first started that nursing homes would triple in number. It's 25 years later, and Rafi, there are less nursing homes today than there were when we started.
Wow, yeah. We know that
Now,
as a fact also in Hawaii, where the population of the elderly and geriatric patient population is increasing, but no new facilities have been built. And I'm trying
That's true around the country. Now, there's an interesting fact that's happening here too, and that is that there are patients getting sicker, but what's happening is when we do the patient assessment systems and we assess the new assessment systems is a new system called MDS, minimum data set, which is about 30 some odd pages of assessments. Some of it for quality of life, some of them of patient functioning, some calculating the RUG scores. There are different RUG calculators that come out of it. And in fact, these weighted values, which are actually used to bill for reimbursement in Medicare, and in some states, Medicaid as well. So these assessment systems have been put into place. Now, these assessment systems have approximately 54 levels of care. If you remember, our RUGs category had 8.
Wow.
You're now at 54 different levels. Now, the lower levels of care is what's very interesting. Those patients that have the ability to somewhat take care of themselves and direct their care and request things and are more cognizant of their condition and their surrounding, those people have been pulled out from the nursing homes, and they are now currently residents in senior living centers or assisted living. There's some 70 or 80,000 of them that have been built across the country. And those people, those entrepreneurs have been having difficulty filling the oversupply. So what they've done is offered monitoring services and assisted living services to attract those patients that normally would have gone into our healthcare nursing homes.
Wow, that is unbelievable. So there's actually a lowering of the level of care, but probably much higher risk in terms of malpractice risk or ensuring the patient's welfare risk. But so will you be able to modify your services, your tracking services, your billing services, your monitoring services, medical dispensation to suit this new reality?
Yeah, we do. We actually do. In other words, when we have a multi-level of care, the assisted living is a very scaled-down version of the nursing home package.
Okay.
It doesn't have quite that level. But you have assisted living, you have independent living, you have a whole continuum of care that you're seeing today. And this is something that I believe is a big trend. I have something that probably would shock you.
Yes. Shock me.
The nursing homes in New York, mostly in the 5 boroughs and in Long Island, are running anywhere between 5 and 10% vacancy rate.
Wow. Is that because of the high cost?
No. That's because of the drain for the low care patients. Those low care patients are being pulled out into other areas, being taken care of at home, being taken care of through home health programs, and mostly through assisted living.
So there's a whole reorganization of the geriatric healthcare delivery services. And who's taking care of the subacute hospital care, the chronically ill who may not be geriatrics?
They're getting shipped out to the nursing homes. But the nursing homes have a big problem now, because now you're getting a patient with extreme high levels of care and sometimes medications that can run in the hundreds to thousands of dollars a month. If they're not careful, a nursing home can lose their shirt taking in the wrong patient.
Mm-hmm, I see. Let me ask you something else. Now, one of the philosophies that's perhaps changing in the field, so to speak, is the return of the care home. It used to be apparent in many states that the family would take in perhaps 3 to 5 elderly geriatric or chronically ill patients and take care of them at home. Some states still permit this under the Long-Term Care Services Acts that are state mandated as opposed to federally mandated services. Now, we have that in Hawaii as well, this tendency. So you have a couple perhaps taking care of 5 people in a large home, each one with a separate room, and so on. What kind of services are you gearing in terms of monitoring services? Because I think that I'm loath to almost call you a healthcare management information systems company and perhaps a tracking company, perhaps keeping track of what's going on, a surveillance company. Perhaps you should get together with the security firms. I mean, is your mission being changed when you have to take care of visual and data and blood pressure monitoring and cardio monitoring? We had a show last week with Dr. Dan Davis, the founder of Eye Care Technologies, which is giving medical care via the computer and the web. Perhaps also your services have to integrate with those kind of providers and team up. Perhaps the billing has to be based on the level of services with the patient's acquiescence to receive care via the internet.
Well, I'm not sure. If you're talking about the patients being taken care of by couples or family, monitoring them would involve a lot of invasion of privacy. I don't know that we'd be able to do it like through a security firm. We'd probably be forced to have them fill out forms and making sure that they did it with spot checks. I will say that it might be a problem, considering that the nursing homes typically are delivering a lot of services to older people. Those services certainly could not be delivered in the scenario that you have. In other words, if a person's at home, They're at home, but there's not going to be a physical therapist or an occupational therapist, or
I see.
You know, they may visit once in a while. That's true, but they're not residents, and they're not there on a continuous basis, so that you can have an ongoing and frequent program for those patients.
I see.
The interesting thing is that the government is trying to do studies now to ascertain just how effective these programs are in the first place. So that remains to be seen as the government does their evaluations to see what.
Let me leave you with another word, just perhaps. I don't know if you remember when we switched from the PDP 8 by digital, we switched to PDP 30s or 10s, 1030s.
It's actually PDP 11.
PDP 11, correct. And then digital went by the wayside. And I was still mouthing the mantra to many, many clients around the United States that all this perhaps this attraction to PCs was just temporary. The real action would always remain in big hardware machines, the big IBMs. That were the only ones that are suitable to deliver medical care and monitoring of records and so on. And I have to say that I had to eat my words later on as I watch almost all the systems go to PC-based systems with the servers and so on. What happened there? What happened to my vision of the big machines everywhere?
Rafi, your vision was not wrong. Let me explain.
Okay.
PCs. Let's not discuss PCs because they're large input devices. But let's talk of handheld, which is very, very popular today, such as your iPhones and your iPads, your Android devices. Those devices are very, very effective for people to capture data at a point of service. They can capture the data, and they can display data, but the real workhorses behind the scenes are the large servers that are going through the data and checking the blood pressure over the last 5 weeks, or checking the person's glucose levels over the last couple of weeks. Those monitoring systems that are calculating and ensuring that the systems are working effectively and the patient is really being taken care of, that work is not being done by the PCs and the little handhelds. The handhelds are bringing the data in, they're bringing the data out, they're giving wonderful access to the data, they're giving you ease of capturing the data, but the analysis of the data, the storing of the data, the grinding and crunching of the data, that hasn't changed. Your vision really is still in place. The only thing that you need to do is expand your understanding of the total system. It's a complete ecosystem.
Thank you so much, David. I'm going to have to cut you right off here. We've had a hot time over here with Dave Pollack, CEO of ADL Data System. It's been a real mind opener. We're going to have Dave Pollack back with us once again to talk about some of the latest innovation in healthcare management information systems. You've been with me right here on Boritzer's Bio Briefing. You're hot, we're not, but we'll see you again next week. For me, Rafi Boritzer, aloha.